Okay, another great episode. We're just rolling right now on the Ortho Show. I really want to describe this one as an educational episode. We're bringing on John Knab. He's an orthobiologics pain management specialist down in North Carolina. He is literally one of my go-to guru people when it comes to injections type things for orthobiologics, which is like PRP and BMAC. But he also uses other modalities such as shockwave. And yes, he's a big laser fan, as are we. So it's a great conversation about what you as the listeners need to know about orthobiologics. How are they used? What should you be paying? What's their safety, etc. It's a great episode. Take out a pen and paper. You're going to love it. Dr. Scott Sigman, hashtag follow the fro.
From Medical Media, this is The Ortho Show.
Hello, world. Dr. Scott Sigman, your favorite opioid-sparing orthopedic surgeon. Yes, here for another episode of the even more popular The Ortho Show podcast, where we bring you the best of the best in orthopedics. We're going to pivot a little bit this week. We have one of my gurus when it comes to orthobiologics and the things that we use to try and help our patients. That's Dr. John Knab. He is a pain management specialist who is an expert in orthobiologics. He's in Wilmington, North Carolina at the Center for Pain Management and Orthobiologics. He's trained as an anesthesiologist, but he gave that up pretty quickly. But John, we are thrilled to have you on the show. Thank you so much for taking some time out.
Great to be here. You have likewise been an inspiration for me from afar. So I'm happy to be here and tell you everything I know, which is limited. It's a lot less than you would imagine.
Well, you know, as we get older, the more we know about less things. And that's what makes us experts and masters through the things that we do. And when it comes to orthobiologics in particular, there's a lot of gray areas out there. There's a lot of things in the wild, wild west that are not great for patients. So we really want to educate our listeners today and really, explain to them what's the good, what's the bad, what's the ugly. And I can think of no one better than you to help us to do that. So we're so happy to have you. So look, man, we always start where it starts. So we have some shared history a little bit. Through the little research we've done, you went to Hingham High School, so I'm assuming you spent a bunch of time in Massachusetts. So tell us about that. Are you the first doc in the family? Were there other family members? What was it all about?
Second and only doc. My dad was he was a general surgeon at Brockton Hospital. Moved up to Manchester, New Hampshire. So he was up there at the Hitchcock branch down in that region, which is up for you. And but he could not convince anyone except me to go into medicine. Yeah. And then I kind of followed my brother from Hingham High up to Middlebury College in Vermont. I probably wouldn't get in nowadays, but they let me in back then and stayed.
That goes for the two of us. I wanted to break in there because I was at Tufts undergrad half the time with you. I was there, was breaking through in 82. I was at Tufts from 82 to 86. Did you do any sports while you were at Middlebury?
I was in the on the rugby team. So that involves a lot of playing and some good after fun too.
Yeah, I was a little smarter. They actually gave me a helmet, unlike rugby players. I played lacrosse at Tufts, and just like you said, I'm pretty confident I would not have made the lacrosse team now. As you know, they just lost in the NCAA championship to Salisbury State, so they've had a tremendous team. But we always made that trip up to Middlebury, for the college lacrosse games, and I'm sure it was a great 4 years for you, great institution, great learning institution that set you right. But then you got stuck up there, man. What was going on? Then you decided to go to university. You just traveled over to Burlington from there.
Yeah, well, it's not too much of a trip. And again, they let me in. It's a great college, geared towards primary care, actually. So once I got into my rotations, I kind of went in with the thinking I was going to be following my dad into surgery. But I think the pivotal moment for me, with med school, starting my rotations was going up to Maine Medical Center, and I don't know if you've been in Portland, but like the summers in Portland are beautiful, right? As are the
Gorgeous.
winters, but gorgeous. And so, I'm in my surgical rotation, orthopedics, and, I'm looking out the window. I just picked up windsurfing and, I'm looking out the window. It is beautiful. And I can get down. If I just get out of here on time, I can get down and be on the water in like 15, 20 minutes and get in, a session. And of course, the chief resident is much more interested in looking at the x-rays from today's cases and going over the trauma cases. So I realized this might not be for me. And so I kind of migrated into anesthesiology, with the ology, that's the Greek root for easy. I
I don't know, but no, you're just, passing gas is a big responsibility, man.
It
It's
is.
they're really, I mean, you don't get the patient interaction like you do as a doc who's seeing patients in the office like you do now. But but it is a great responsibility for sure.
It is. But I do remember being in my third or fourth year of residency after kind of deciding I wanted to be in anesthesia, and it was kind of the end of my residency, which was out in Seattle. So I decided to get across the country to go out to Seattle, and I was kind of at the end thinking, all right, do I love this? I like it. Do I love it? And I think one of the orthopedists who I'd been working with all year, knew him pretty well, and he kind of says, "Hey, anesthesia, hang another 5-liter bag for me." And kind of that to me was like, all right, I gotta think of something else. And so I found interventional pain management as a fellowship that I wanted to do. So after my time in Seattle at Virginia Mason Medical Center, went down to UC San Diego and did a fellowship in interventional pain. And that was in 97.
Which was early. I mean, there wasn't that much interventional stuff going on at the time. And I guess there are a couple pathways in, right? You could be a physiatrist, PMMR versus anesthesia, both sort of work their way in. But it sounded to me like you wanted to have more direct interaction.
I did.
With patients rather than hiding behind the curtain and hanging that 5-liter bag for that doc.
That's right.
And so did you practice anesthesia at all for a couple of years before you moved back east?
So I practiced with it's a 170 person group at the time, 170 anesthesiologists in San Diego. So it's a ASMG, Anesthesia Services Medical Group. Liked it. And I told them, listen, I do not want to practice anesthesia. I really want to do pain. They had me, doing some pretty easy cases at the surgery centers, but I was really kind of focused mostly on interventional pain. And, remember back then, we didn't know about the opioid crisis. I came out of a fellowship that was really, really geared towards, not just the interventions with the needles, but also with the concept back then that opioids were okay. This was before we knew anything. We knew nothing about the risks and pitfalls. And, if you could imagine wiping out everything we know about the dangers of opioids now, we were told there were no risks. As long as the patient is taking it for a medical reason, there are no risks. So I came out of that class, okay? And we didn't really know any better until we knew better. So I worked in San Diego for 3 years.
Yeah, I mean, I think it's fascinating because again, you and I are contemporaries, and we were taught, look, what you do is you're going to hurt people, right? You have saws and drills and stuff, and you need to make sure that people are out of pain, right? And you're going to use these opioids because they're inexpensive and they're really not addictive. And we just we're caught up in this culture, and the entire medical society and system, doctors, nurses, hospitals, the regulatory boards, all got caught up on it. And we just kept giving out more opioids. And then we just kept looking at each other and saying, why are these people keep calling for more opioids, right? It's like the refills, and then the belligerent people would be calling. And then it was you were managing opioid addiction in addition to whatever else you were doing. If you were involved in surgery or intervention of any kind, you had to manage these poor people that were stuck on meds that we started them on. And I always say, addiction chooses you. You don't choose addiction. This is a genetic predisposition that if you take this pill, you're probably going to be highly addicted to it, and it's going to happen pretty quickly. So, yeah, so it was a tough time. It really was a tough time. So it was interesting. So, all right, for our listeners, okay, so you finally get it. You're like, okay, this anesthesia thing's not for me. I love this pain management thing. I'm early on. I got the opioid crisis that's happening all around me. Not really sure what's happening, but I'm going to move to North Carolina, and we're going to do this pain management center. And let's sort of fast forward so our listeners understand, what do you do on a daily basis, and what kind of patients are you seeing?
So since about 2015, I've kind of figured out why I'm here, what I want to do, what my medical calling really is. And that's kind of a combination of traditional treatments, which are steroid-based, burning nerves when we need to arthritic joints in patient spines, putting in implants that are kind of like pacemakers for pain, spinal cord stimulators. Mixing that up with what I really love is treating musculoskeletal injuries with patients' own cells, primarily PRP, which stands for platelet-rich plasma. So where we can take a person's blood, spin it down in a centrifuge, take the platelets out of the blood, and inject those into damaged joints, damaged tendons, around injured nerves. And with that and some time and some additional kind of adjunctive therapies, we make people better with their own cells. And so my patient age ranges from low teens all the way up to high 90s. And so we are not just treating the ultra elite athletes. We're treating the weekend warriors. We're treating mom and pop. We're treating teachers, firemen, policemen, and everyone that's in our community. So treating them as we would kind of treat anyone in our family with things that are relatively well proven from a scientific basis, not necessarily accepted by insurance as something they want to cover, but reasonably priced treatments that can get people feeling better, sometimes without surgery. So
that's great. So let's break all that down for the listeners, because I want to spend a bunch of time really educating everybody about all of these various modalities. So first and foremost, I think it's fascinating that most pain management specialists have gotten out of the business of prescribing opioids and managing patients' pain with opioids, right? And so I'm assuming like in 2015 is the day you talk about it, but there was a transition that happened to say, okay, opioids are not good. There's a lot of ways that we can treat patients' pain, especially opioid naive people. Yeah. People that have never been on opioids should never be started on them for a chronic condition, right? If you do, you'll never get off. So you've come up there, and we've all come up with solutions that can help with patients' pain, that avoid the opioids, potentially avoid surgery, keep our patients moving, and provide them healthy solutions. So I love how you started with PRP. Great explanation. My mother Judy could understand that quite clearly. And so PRP is one of the main modalities that most of us are using. And again, you're taking your patient's own blood, so it's not being manufactured in a pharmacy somewhere. It's not getting manipulated and moved around. It's basically your own stuff that we mix and then we put back in, and these growth factors have been shown to help. So what do you tell your patients about the literature, right? Because there's so many old school docs out there that are still saying, don't do these orthobiologics. Show me the randomized controlled trial. They don't work. They're super expensive. But what do you tell your patients, and what's been your professional experience?
Right. So, I heard a great quote this weekend. I was at Toby, the orthobiologic meeting. And one of the guys said, there's real good evidence-based literature published that shows evidence-based medicine doesn't work. It's true. You can find a study to disprove any study if you look hard enough. But for most of the simple things, let's just take a knee. Our options are basically steroid. Okay, there's gel. We can use the gel shots. We can use PRP. We can use stem cells, and we can have surgery. So let's just keep it like steroid, gel, PRP. PRP beats gel, and gel beats steroids. It's simple. And you don't want too many steroids. Steroids are not good for our tissue. They break down tissue. They break down cartilage, at the doses that sometimes you brutes in surgery do. We don't want that. We can do better. We know we can do better. And the studies that are out there now show that we can buy people more time using PRP compared to the gel shot. So for people who don't get better with just a steroid shot, once a year or something really, really infrequent, we got gel. If that doesn't work, then we can try the PRP. And again, you want to have this done by a person who knows what they're doing. They're using image guidance, just the way we do all of our injections. You want to have someone who's using ultrasound or using fluoroscopy, if possible, and preferably so that you're getting the stuff to go where it's supposed to go.
Okay, great explanation on the PRP side of things. So I'll tell you a story. So I'm in, by the way, Steve Sampson in the Toby conference. We want to give a big shout out. Unfortunately, I had to back out at the last second. I was scheduled to give a talk, but really one of my favorite orthobiologic conferences of the year. It pulls together experts that really help to try and really hone in on what the literature is and what the truth is as we try to use these. So what are you charging for a patient for a PRP injection for the knee?
Well, it depends. It's kind of like I tell patients, it's like going to the car wash. And I don't mean to dumb it down, but it's like, depending on what you need and what your pathology of your knee is and how serious you want to get about it, you can press the easy button and you could have a PRP treatment that's $1,000, unless you're a teacher and you're getting a discount, unless you're a cop and you're getting a discount, unless you're a fireman, you're getting a discount. Or if you're a VIP, veteran in pain, you're going to pay $0. Okay, so we participate with Veterans in Pain program that treats
love that.
Treating our veterans with not just PRP but stem cells. So we have some buy-in from industry, so from some of the kit manufacturers that give us kits, so we can donate our time, our talents to these veterans. So it depends, but like in my practice with what we're doing, you're going to get a intra-articular PRP treatment about $1,000. Now, if I take your plasma and concentrate it down, or if I add gel to it, or if I'm going into the meniscus and I'm going into tendons and I'm going to be doing a procedure that takes not 5 minutes or 10 minutes, it takes an hour. Well, that's going to be more. So you could probably get up to $1,750 for a PRP injection, but you have to be comparing apples to apples.
Yeah, one of my favorite stories was in Vegas. I'm in a cab. I'm heading to the Academy meeting, and the cab driver says, "Oh, you're one of those orthopedic doctors. I just had both of my knees injected, and it was $5,000 a knee, and I think I'm starting to feel better. I took out a home equity loan for it, and I'm on my way." And you cringe when you hear these stories. There's new corporations that are setting up these new centers and shopping centers where you can go in and get crazy quotes on what it costs. So really, for our listeners, identify someone that does this on a routine and regular basis. Great advice on ultrasound guidance to make sure it goes into the right place, and make sure that it's reasonably affordable and it's a number something that you can afford, but that also makes sense to what seems out there in the marketplace as well. So that's all right. So PRP, I think we covered that pretty well. So the next one up is the bone marrow aspirate concentrate, which is known as BMAC. I have not gotten to the point yet when I can take a large needle, stick it into somebody's pelvic bone, pull some stuff out in the office, and then go ahead and inject that. Now, I know that a lot of people are. Our dear friend Donnie Buford, who is my other, go-to guru guy, I do see that a lot of it happens in the operating room. That makes sense to me. A patient's under anesthesia, you have controlled environment, you can identify things and sort of add it in. Are you doing any BMAC in the office?
We are, and surprisingly not as painful as people might think. So if you use enough of a local anesthetic and the patient is not too fluffy, obviously you can feel the posterior iliac crest very easily, most people. And if you use not even a ton of local, 10 cc's of lidocaine or bupivacaine, ropivacaine, whatever you want to do, go down to cortex, give it time, give it 10 to 20 minutes. You do not feel that needle going through the cortex, and all you feel is the rapid pull when you're doing this kind of Philippe Ernogut technique, where you're doing a rapid pull of the syringe to get a highly pressurized aspiration of the marrow. that hurts like a toothache for a very brief period of time. And so depending on your thought process, most of us believe that there's benefit in taking out about 60 cc's and concentrating that down into anywhere from 8 to 10 cc's, maybe a little bit less depending on the joint. Most of us think that by doing so, concentrating down the bone marrow aspirate into BMAC, bone marrow concentrate, we do a better job of getting a higher number of stem cells. So yeah, it's not as bad as it sounds, and it can be done just in the same way you would do almost any procedure in the office. Surprisingly easy. I think Donnie's video is like a 10-minute bone marrow procedure. It's really that quick. And if you don't get too crazy and try this multi-site aspiration technique, it's really very quick and painless for the most part.
Yeah. So for my listeners out there, if you're going to come and see the Fro and you're going to see me in the office, I'm telling you right now, if you want a BMAC injection, you're going to Wilmington, North Carolina, or you're going to Dallas, Texas. And those are my two go-to people that do a lot of this. And that's what I would recommend. All right. What are you charging? I think that's important. Let the people know. BMAC injection, how much?
So it comes back down to like, what are we doing? Are we going, like intra-articular? Are we going to intra-articular, extra-articular, multiple sources, multiple sites? 3,000-ish for, the BMAC, up to 5,000. I've never needed to, charge more than that. And, I think if you hear a number that's kind of nationally the average for that, that's probably about what you would hear from a lot of places. I know, someone who's as an expert as Donnie is, I think he charges less. I know this because my son's gone to him. So,
well, I think that, Donnie's very conscious of that. I think, one of the things that I love going to these orthobiologics conferences and these docs that are just so energetic and enthusiastic and passionate, and they all get up there, they all kind of say the same thing. It's like, this should be covered by insurance. Let's keep doing these studies so that eventually it's going to be covered by insurance. But the hard truth is, it's just not going to be. In the current pathway of the autologous process of being able to take care of your blood, of your bone marrow aspirate concentrate, we definitely know that there's evidence that it works. There's no question. Anybody that says it doesn't is crazy. But at the end of the day, CMS is not going to pay for this until there is some really big, arduous, PMA study that's done at about $10 million per study with a randomized controlled trial to develop a CPT code. So probably where it's going to happen is through big pharma, right? Identify the growth factors that are in the PRP, that are in the fat stromal cells, that are in the bone marrow aspirate, identify the pellet, rather than the shotgun that works, and then they'll pay for it to go through, and eventually it will get paid for. But, so how old are you, John?
57.
57. So, unlikely. Would you agree
not my lifetime?
Not in your lifetime that these types of modalities are going to be covered by insurance companies. So look, we're limited at this point. What will the insurance companies pay for? They won't even pay for the gel shots in Massachusetts. They'll pay for a short-acting steroid. Some will pay for a long-acting steroid. And then after that, it's like, sorry, you're on your own. So, all right, that was good coverage. Do you do any stromal? Do you work any lipogems, or do you do adipose tissue at all?
So we've been limited by our medical malpractice carrier, and for that reason, we've kind of switched over to the one that's being used by Toby and ASIP right now. So they're a little bit more in line with the fat. So that using fat per stem cells requires the use of a miniature lipoaspiration, so a miniature liposuction. And so
yes,
certain malpractice carriers don't really get that and think you're operating outside of your field of expertise. So
interesting.
We have, I'm very forthcoming with everything new that I'm doing with my carrier, and I would advise any other physicians who are considering adding any of these new things to their practice to do so as well. Because at the end of the day, something goes wrong with a lipoaspirate, and you haven't told your carrier about it. It might
no, it's for sure.
Yeah.
And I don't want to give you a hard time, but you have been using the S word, which is interesting. Scotty Bruder is another, real go-to person for me, who's in the consulting industry and the regulatory side of things. So just for our listeners, there really is no orthopedic on-label indication for the use of stem cells. So you have to be careful about whether you call them progenitor cells or orthobiologics. There's a lot of names for it. But beware when you go to a doctor on their website or on their thing if they're talking stem cells, because there really is no direct indication in orthopedics for that. But I just want to make sure in case somebody's listening was to give us a hard time. All right, so those are the stuff that you're injecting. You had a really nice post on HA just yesterday or the day before. I was looking at it, and there's some clinic out there charging like $5,000 for a single use hyaluronic acid, which is the gel shots that we use, which is like a lubricant for the knee joint. That's crazy that people can get away with that.
It's crazy. And I think it's a combination, as I was saying, it's that the patient said, yes, give me the gel. And the physician decided to use the most expensive version of the gel, a single shot gel. And patients' high deductible insurance company has a high allowable for the J code that was submitted. So there's nothing illegal. It's just, is it really in the patient's best interest to let them spend their money on that particular single injection? I don't think so.
No, that's terrible. I mean, look, I can tell you right now, in Massachusetts, you got to pay out of pocket for it for most insurance companies. It's like $300. Okay. Anybody that's spending $4,000 or $5,000 on this is just being taken, for a ride. So be careful about that, people. Make sure you check into various options that are available. Okay, let's talk about something that you and I share, which was a sort of a way in which we were introduced. And I'm going to start with this. And on the first day, God said, let there be light, right?
Yeah.
Healing with light. So not only do you use these autologous ways or using patients' own tissues to be able to help them, but you believe in external healing options as well. And one of the things that you're passionate about, as am I, is the use of laser for musculoskeletal injuries. So tell us about your experience with that, how you use it, and what's been good for patients.
Right. So we use laser. That was my first, entry into what I call non-invasive orthobiologics. So things that have the same effect on the body as PRP, as bone marrow aspirate, as bone marrow concentrate. We are triggering the same healing pathways with these external machine energy devices like laser, like shockwave, like EMTT, in a way that we can provide the patient a chance to get better without even a needle going into the body. So my first entry was with laser. You and I share the same manufacturer, different machines. I'm not going to mention the name. I'll let you do that. But my first device.
It's my show, so it's okay to be subjective. Okay.
Okay. So
you can say whatever.
Anyway, we had a competitor's product. Okay. And that was our first laser. And it's pretty cool, actually, and it's very versatile for what it does. It's a class 3B, so class 3B being less powerful than the class 4 laser. But after having that for a while, of course, I'm on the internet and I see that MLS, and so this robotic laser, and I don't know what they were showing, some athletic team that were using like the immediate case of the I wants, and so I saw that. I don't think at that time you had started ortho lasers. So at that time it was still kind of just this M6, looked pretty cool. So we had the other laser, we got the second laser, and of course class 4 laser, 2 wavelengths, some that's going to improve blood flow, that's going to reduce healing, and trigger the healing responses. That for me, combined with the fact that you can go in and program your XY coordinates to match your patient's needs and then leave the room and do something else. That was like, oh my God, this is beautiful. Like, patients don't want me sitting there talking to them. I don't want to be sitting there talking to them. They just want to get the laser. And so that to me was just a real turning point in how I thought, like, wow, I can expand my knowledge and my brain and my smarts to patients without having to spend every single minute of my time with them. And I'm giving them, great opportunities for healing. So
how are you using it? Which patients are you using it for?
It doesn't it ranges from, post procedure, shoulder, Post-procedure, we do a lot of spine work. So anybody who's had a spine treatment, we want them to have a brief period where they're having an inflammatory response so that that can be the first step of the healing process. But the minute that stops, 7 to 10 days, they're coming back to the office and they're going to get weekly sessions. As a part of that, $1,000, that's built into that price. They're going to get laser treatments for 3 or 4 weeks. And so spinal patients, hip, knee, anybody we see, believe it or not, we see some patients who've just had surgery on their knees, hips, or shoulders, and they come to see us because there's no ortho laser franchises down here. So, post-procedure, helping a patient who's having trouble with swelling or pain or restricted range of motion after surgery, great case use for laser. I've used it on a guy with trigeminal neuralgia. I've used it on a guy with, non-healing ulcers. I've used it on a patient after seeing what you did during COVID. I have a setting on my machine that says Sigman protocol. And so it's, I've used it on a patient's wife who I was seeing for something. I was seeing the patient. I said, "Where's your wife? She always comes with you." She had terrible post-COVID, pneumonia and was not getting better. 3 or 4 treatments using your protocol. I mean, incredible. That was groundbreaking work that you did. I was blown away by that. So kudos on that. So
Yeah,
really, there's very few places where I wouldn't use it, especially for someone, if I do a rotator cuff procedure with PRP, BMA, BMC, the last thing in the world you're going to want to do is subject that patient to shockwave. They're so inflamed, they just can't really tolerate much. So the more inflammatory a case is, the more likely I am to apply laser. The more patients just coming with a chronic pathology, that'll be a part of what we do. We might combine it with some shockwave and electromagnetic therapy.
Yeah, I mean, there's a couple of amazing things that have happened, right? The American Academy of Orthopedic Surgery for the first time in 8 years revised their guidelines for the treatment of knee arthritis. They took a look at the literature, they did a deep dive, and guess what? Laser wound up on the list. So yeah. AAOS now basically states that laser treatment is a viable option for the treatment of knee osteoarthritis. The Centers for Disease Control just updated their guidelines for opioid prescribing this past April. It is now really a very important document that gives primary care doctors and people alternative options. And they literally list laser in for acute, subacute, and chronic conditions such as back pain. So laser is now also validated by the Centers for Disease Control. So you gave a wonderful description. People always ask me, "Hey, doc, how does this laser work?" And I think if you think about, you talked about COVID, right? People think about the cytokine storm, those cytokines, which are these proteins that create inflammation. The laser blocks the formation of those, and it basically helps to eliminate this inflammatory process, which means less swelling, less pain. And that's the concept for ortho laser. We took the MLS M6 laser to start, and then the M8 laser came out, which is more powerful than the M6. The only way you can get that's through ortho laser. But we have a successful franchise across the country, and we're growing, and it's from doctors like yourself that have taken the plunge to try something new and different and have really amazing results and be able to share that. So thank you for your work within laser and your ability to share that with our patients as well. Yeah. So look, John, I think we're coming about to a close at this point. This was a really tremendous episode because it just drives me crazy when I hear these stories about how patients are taken advantage of by these doctors really for their personal financial gain rather than what's in the best interest of patients. So we've educated them on PRP, we've educated them on BMAC, we've talked about laser. I know you do a bunch of other modalities with shockwave therapy and other things as well, but I want to thank you for being a true leader within the world of orthobiologics and really doing your part to educate doctors and patients in the benefits.
My pleasure. My pleasure. I hope we can get together at a meeting sometime again real soon. I thought I would see you out there, Toby. So now I know why you weren't there. And maybe catch you at the next IOF or one of those meetings.
No, for sure, John. We're gonna bring you back on as you get more and more stuff going, and let us. I love these sessions when we can really educate our listeners and our watchers now on our YouTube channel. This is Dr. Scott Sigman, #FollowThePro, host of The Ortho Show. Till next time.